It carries, obviously, membranous nephropathy will particularly for those people who have what we call the high risk of progression disease, which is characterized by a higher rate or degree of protein spillage in the urine with its associated consequences, including low albumin in the serum, high cholesterol with potential cardiovascular complications. Also, when we lose protein in the urine, we are also losing antibodies, and that predisposes the patient who has this high degree of proteinuria to higher risk of infections. They're also at higher risk of clots in the venous system. So it is, unless we reduce the proteinuria, the complications could be life-threatening. And also, there are plenty of studies showing that the higher rate of proteinuria, the higher likelihood that patients will start losing renal function, and in time they will be on dialysis. So far, the treatment for membranous nephropathy, there is no standardized treatment, except that we use non-immunosuppressive agents to decrease the proteinuria. And for patients who persist in their proteinuria despite measures to where medications like ACE inhibitors or ARB, for those who do not respond to the reduction in the proteinuria, they will need immunosuppressive drugs. And many patients, almost 75 to 80% of patients with primary membranous nephropathy are having an autoantibody, which is the disease is an autoimmune disease, and the target organ is the kidney, or the basement membrane of the kidney, and that's where the inflammation is set up because of the antigen-antibody immune complex generating an inflammatory response that lead to the proteinuria and the decrease in the GFR. So we can measure the antibody in the serum, which is known as antiphospholipase A2 antibody, and the titer of that antibody would correlate with the degree of inflammation, and the reduction of this antibody also will precede and can predict the improvement in the proteinuria if you are able to reduce the level of that antibody or titer of the antibody in the serum. So the crux of treatment then in those patients who require immunosuppressive agents is to suppress the immune response by decreasing the amount of antibody production by what we call the B cells or plasma cells. So far, there is no standardized protocol. There are different immunosuppressants that we use, but every regimen has its own outcome, its own side effects, and we are still looking for the optimal therapy to control the disease. It targets the B cell producing plasma cells. It's predecessor drugs of prior in the same class, which is anti-B cell therapy, which is the B cells are the antibody producing cells. The precursors, the plasma cells is more mature in producing the antibodies. And in this case, if you suppress the later progenies, like the plasma cell, you are preserving the earlier lineage so that you can preserve immune response to vaccines, for example, so that the burden, because the downside of any immunosuppressive regimen we use is by its definition, we are suppressing the immune system in order to prevent the inflammation in the organ affected, in this case, the kidney. But at the same time, when you suppress the immune system, you are also suppressing the response to infections. So that's the other side of immunosuppression is increased risk of infection. So if you have a more specific agent that would target the more of the cells that are producing the antibodies and leave the earlier lineage to be able to respond to vaccine, that might be associated with less risk of infection, and that's unique about our agent in this study. The prominent study design is patients who meet the criteria, which are basically patients who fall into the category of high-risk patients, moderate to high risk, which is proteinuria, with nephrotic syndrome, and biopsy is also in patients who actually part of the inclusion criteria, patients who have anti-PLAR2, provided that the kidney function is more than 50 ml per minute in the GFR, we don't need a renal biopsy. Those who are less than between 30 and 50% or 50 ml per minute GFR, they need a renal biopsy. Now, the design of the study is those who qualify, then they're randomized in a 2-to-1 ratio to receive the antibody versus another standard of care therapy or one of the agents, immunosuppressive agents called tacrolimus, which is a class of calcineurin inhibitor, which is another immunosuppressive agent. So the good thing about the study is that you are randomizing the patient to 2 active treatments that are in a 2-to-1, with the antibody being a 2-to-1 ratio. The beauty about the study is we are giving the injection once a week, and for 24 weeks, we give an off-treatment period, and then we resume the treatment at week 52. Now, the beauty about the study is that if there is no response or less than optimal response as defined by reduction in proteinuria, then the patients have the chance to go to what we call rescue therapy, which is a very important part of the design of the study, which is and the criteria for the rescue therapy. If we see that the kidney function is decreasing more than 30% from baseline, or the proteinuria is also decreasing in the form of increase more than 50% from the baseline, and that's at week 24. Then we can go do rescue therapy. So if the patient is on the tacrolimus arm, they can receive the antibody. There is a reduction of antibody, the anti-PLAR2 antibody, and that's also associated with a reduction in proteinuria, and that's what led to the development of the phase 3 trial. Obviously, it could be adopted as a standard of care therapy.